Good evening, everybody. Siobhan, are we ready? Let me see. We're okay to start. Okay. All right.
Perfect.
Great.
So here, if you see a link, that means there's some questions popping up.
Okay.
So you can answer them.
Very good. Thank you. Good evening, everybody. I apologize for the delay. I had some trouble logging on. Tonight, I have the rare opportunity of spending some time with you over this platform. And I hope that I will get the opportunity to answer any questions you might have related to the carrier genetic screening that we offer to all our patients that are presenting requesting fertility advice. I would start by saying, first of all, that I have no disclosures and no conflicts related to this talk. I have prepared for you tonight a slide presentation. And at the end of the slide presentation, I will open this forum, if you wish, to all of you so that you can ask your questions. And you can, of course, send your questions to us via the chat function. Just know that prior to me finishing this presentation, I can't really see your questions. So wait until the end of the presentation for that. I'll do my best to answer all of those. My goal, obviously, is to answer for you tonight two very basic questions. What is the preconception genetic testing? Why do we offer it? What kind of information do we get out of it? And how do we use this information we find about you and your family? It is important to understand the nature of the test, its abilities to detect genetic disorders, its limitations, technical limitations and others, its applicability to each individual case, and of course the need for follow-up, which can be follow-up with your primary fertility physician or on occasion with a geneticist. Without understanding the nature of the test, I would say that the reaction I get from the patients varies from negative feelings to almost expecting too much from the test, unrealistic expectations. So I'll give you some examples. On occasion, I'll get a couple that has read a lot about genetic testing and hopes that the genetic testing can really detect every abnormality that could potentially be affecting their child. I've heard you can test for a lot of things. I want you to test us for everything. On occasion, I will get a couple that is more doubtful and ambivalent about the test, potentially thinks that the test doesn't really apply to their situation. Everybody in my family is healthy. Do I really have to do this? And on occasion, we'll get a couple that has been in this fertility journey for a very long time and feels that this is another obstacle on their way to having a baby. We're here to have a baby. We don't want to waste our time doing additional testing. The results will not really change what we do. So before I talk to you more about the testing, I want you to first understand the difference between preconception and prenatal diagnosis. These two definitions refer to two time periods that are different. Preconception refers to the time leading up to the establishment of the pregnancy, while prenatal is more referring to the time period from conception until delivery. So any testing and any interventions that will be offered to the couple in the preconception period will take place prior to the establishment of the pregnancy in the time period leading up to implantation and conception. while any testing and interventions that will be offered prenatally are offered after the pregnancy is established and take place for the most part either at the end of the first trimester or early in the second trimester. Certainly, both take place prior to the birth of an affected child. What are the advantages of preconception testing over prenatal? As you understand, since the testing is performed prior to the establishment of the pregnancy, interventions can take place in the time period leading up to conception. Interventions can take place prior to the couple conceiving. These interventions include pre-implantation genetic testing, which is a cutting-edge technology that we're going to talk a little more about in one of our future webinars. So please stay tuned to get the updates on when that will take place. But briefly, PGT includes the creation of embryos through in vitro fertilization, the testing, the genetic testing of the embryos prior to the establishment of the pregnancy, the selection of unaffected embryos for transfer into the uterus, with the hopes that this way we will increase the chances of a couple to have a healthy offspring. How about prenatal diagnosis? Prenatal diagnosis, as we said, takes place after the pregnancy is established. For the most part, we try to do most of it towards the end of the first trimester, early second trimester. And the testing includes amniocentesis and chorionic villus sampling. An example of non-invasive technology includes the use of ultrasonography and the utilization of blood testing. You're probably all familiar with the so-called first trimester screening, which is a blood testing combined with an ultrasound and can tell you more about the health of the conceptus, about the health of the fetus. What happens though if the fetus is diagnosed with a genetic defect? What options do people have at the time of prenatal diagnosis? Well, people have the option of using no intervention, which means almost certainly they will be delivered of an affected child, or people have the option of terminating a pregnancy. So I think that at this point, I have convinced you that knowledge is power. You want to know more about your own genetic status. You do want to know more about the genetic status of your baby. But at the same time, timing is critical. Knowing early is important. You want to know as early as possible, and most hopefully, you want to know before the pregnancy is established. This way, you decrease the chances of having an affected child, a couple decreases their need for termination, and the testing and the technology decreases the psychological impact and the stress related not only to the unknown future, but also to any difficult decisions that the couple might be faced with. So clearly, timing is critical. Preconception is better than prenatal. So for those patients that say, I don't need the test, the results will not change what I will do, I would argue that the results might change the way you want to approach this, might change what you want to do. For those that think that the situation doesn't really apply in their family history, I would also say that although we do believe what you say, that everybody in your family was healthy, seemed healthy, was healthy, lived a long, productive life, the testing is not really designed to test the health of your ancestors and this way predict what is going to happen to your offspring. The testing is designed to test and screen for what we call automatic carriers of either autosomal or X-linked disorders. So although everybody in the family was healthy, what we're looking for is asymptomatic members of the family that carry these so-called recessive or X-linked genes. So I know that this is not something probably fresh in your mind, so I'll take a little bit of time and take you back to school, back to your biology classes, and remind you of a few definitions. What's a chromosome? What's a karyotype? What's a mutation? What is a dominant, a recessive, or an X-linked gene? Remember those chromosomes? One simple way to think of the chromosome is that it is a package of genetic information, all the information related to how a human is made, how a human body is functioning, is encoded in the chromosome, which is made of DNA and protein and contains many, many genes. So it's kind of like a recipe book. It's an operations manual. Or, if you wish, it's similar to an encyclopedia. It contains a lot of information about how we're made. What's a karyotype? First of all humans contain chromosomes that come in pairs. So we have 23 pairs, 46 chromosomes total. You can see them lined up in a karyotype. Each part of this pair comes from our parents. One comes from our father, one comes from the mother, one comes from the dad, one comes from mom. So here in the karyotype, you kind of see them lined up. The first 22 chromosomes that you can see them lined up here are called autosomes. They contain information about how the human body functions. While the last part, the last pair, the so-called pair of sex chromosomes, contains the genes that determine the sex of a human. So a female has 2 copies of an X chromosome. A male has 1 copy of X and 1 copy of Y. So when I use the analogy of the encyclopedia, the reason I used it is because you can think of the human body just as contained of 46 volumes of amazing information that is contained and written in 46 volumes. But think of it this way. 2 volumes are written on the same subject. So you have 2 copies for each gene. You have 2 copies for every chromosome. And that's very, very important to remember. Just like everything else, not everything else, most of other things in our body, they come in 2s. We have 2 eyes, 2 arms, 2 legs, 2 hemispheres in the brain. So our body just kind of wants to have a copy of things, right? Same thing happens with the genes. We have a copy, 2 copies of each gene. What's a mutation? A mutation is an alteration of the DNA. It's a change in the genetic information. So somewhere in the chromosome, for some reason unknown to us, there is a change, a mutation. The recipe has changed. If the recipe changes, there is a pretty good chance the product will change. Not every change in the recipe leads to a disastrous outcome. There are a lot of changes that are well tolerated by the human body, but a lot of mutations are associated with disease. So think of a mutation as a spelling error. In one of those volumes, we talked about in some chapter, in some line, there is a change, a spelling error. As we said though, we have a copy for an extra copy. We have 2 copies for every gene. So that comes handy in the situation of a mutation. Sometimes the healthy copy is enough. Sometimes the healthy copy is not enough, and one copy of the faulty gene is enough to cause a disease. That's the situation with the so-called autosomal dominant genes. With autosomal dominant genes, the person that is affected has a faulty copy and a healthy copy. But the faulty copy is dominant. It takes over, and the person that carries that faulty copy will actually manifest the disease. People that carry autosomal dominant genes have a 50% chance of having their babies affected by the same disease that the parent has. Dominant genes are not what we're looking for with our testing, because dominant genes are obvious. What we're looking for is the so-called recessive genes, because with the recessive gene, the parent that carries it has a healthy gene and a faulty gene, but the healthy gene takes over and the person is asymptomatic. What happens in that situation? If this person pairs up with a partner that is healthy and carries only healthy copies of the gene, they have a 50% chance of having an offspring that will be an asymptomatic carrier. Just like that mother, asymptomatic, no risk, no disease. We don't worry about these people. We screen them, we find them, but we don't worry about them. Who are the people we worry about? Who is the target of our screening? The target of our screening are the people that carry both a faulty copy of the same gene. So if this asymptomatic carrier pairs up with another asymptomatic carrier, then they have a 25% chance of having a child that is actually affected. The child is not like the parents. The child is diseased because the child inherited from both parents the defective genes. However, 50% of their offspring will be just like the parents. They're asymptomatic carriers. And another 25% of the offspring will actually be carrying both healthy genes. Just like these unfortunate offspring inherited both of the defective genes, these offspring inherited both of the healthy genes. So we're not worried about these 3/4 of the offspring. Neither one of them is diseased. The only one we worry about is this one. 1 out of 4 children can be affected by a genetic disorder. How about these X-linked? X-linked disorders are carried on the X chromosome. And as we said, the mother has 2 copies. The father has only 1, because the other copy is the Y chromosome, which is what makes the father a male. So the mother has a healthy and a faulty copy. The mother, for the most part, most of the times, is completely healthy. There are some exceptions. However, that mother has a 1 in 4 chances of having a child that is affected. That's the baby boy. The girls will not be affected because the girls have a healthy copy of the gene as well. 1 out of 2 baby boys, though, will be affected because 1 out of 2 baby boys will inherit the faulty copy of the gene. So with our testing, what we're looking for is those healthy, seemingly healthy, asymptomatic carriers. We are very we're very helped, if you wish, by all the information you gave us about your family. But just knowing about your family doesn't necessarily tell us what mutations might be carried in a hidden way in the DNA of your family. This is what we're targeting with the preconception genetic screening. So we understand, of course, that when we diagnose with a mutation, that can be very upsetting, very unsettling. It's not enough that you have to make all these decisions about your fertility. Now we're coming with new information, telling you that there is a genetic condition that you were not aware of. What does this mean for you? For some patients, it feels like they got a bad grade in the test. They take it personally. They are anxious. So I always tell people, first of all, don't take it personally. Mutations happen for a reason, and they are more common than we can actually detect. In fact, we estimate that apparently humans carry somewhere between 1 to 2 mutations each, associated with severe and on occasion lethal genetic disorders when 2 copies of the same defective gene are passed on to the offspring. Some examples that you might be familiar with are thalassemia, Fragile X, cystic fibrosis. Thalassemia is more common in Southeast Asians, and also Southern Europeans, Italians, and Greeks. It's a congenital form of anemia, which can be lethal. Cystic fibrosis is more common in Northern Europeans, and it's associated with disorders, with disease that affects the lungs, the pancreas, and some other parts of the body. Fragile X is associated with mental developmental delays, with mental disabilities. But like I said, mutations happen. They are essential to evolution. There are studies that suggest that many people that inherited mutations had survival advantages in certain situations. For example, we think that cystic fibrosis carriers were more resistant to syndromes that were causing diarrhea or diseases that were causing diarrhea, like cholera. So back in the older years, when there was a pandemic of cholera, people that were carriers of cystic fibrosis had a survival advantage. They would survive over the ones that were not carriers. Same thing with people that have hemoglobinopathies. Thalassemia, for example, alpha thalassemia. We think that people that were carriers of these types of thalassemia had reduced risks of developing malaria. So in areas where malaria was endemic, people that were carriers of these mutations had a much higher chance of surviving. So although you might think like you got a bad grade on your test, you didn't. You were just part of evolution. In humans, perfection includes imperfection. That's how the human race evolved over the years. So don't take it personally. The question is, what are the things we can do to find more about your genetic background, your genetic information? How can we do this? How cheap or expensive is it? What are good times for us to offer this testing to you? So I would start by giving you a little history here. First of all, I would say that over the last 20 years, genetic testing, preconception genetic testing, and genetic testing overall has evolved and became cheaper. So in the very early years, we would offer testing based on people's ethnicity, based on people's ethnic background. Why? Because we had to minimize testing and just focus on what was more common. And certain things were more common in certain populations. But as you understand, people are of mixed background. Quite often, we don't really know all about our ethnicity. And we want to know more about our genetic information. So initially we would offer people of Northern European or Eastern European Jewish ancestry, cystic fibrosis more common. Or we would offer people of Southern European ancestry, testing for thalassemia, or African Americans, we would offer testing for sickle cell. However, nowadays, we're able to offer more testing for the same amount of money it would have taken to just test for one thing. So we have created these so-called panels. Panels can be fundamental, like very basic testing for the really most common mutations, or a little more general, a little more comprehensive testing for commonly seen mutations. And by saying commonly seen mutations, we mean mutations occurring at a rate of 1 in 25 to a rate of 1 in 100. And we also have more expanded, really more comprehensive panels that can test for things that are even more rare than that. So we can offer any one of these to the couples, and they can choose based on their interest, background, or what their insurance covers, what they want to test for. We also have different ways of doing the test. We can decide we're testing the female first, and if the female is positive for something, then subsequently we can check the male. Or we can do it in a more synchronized way. We understand we don't have time to come to the office all the time to get tested, so we can take the blood out of both partners and either test both partners at the same time or test the female first. And if the female is positive, then we utilize that blood sample we've taken from the male partner to test. But in that case, we don't have the male partner come back to the office to be tested. So what if both partners are positive? What can we do for that, right? Okay, we're sharing this information with you. We cause some anxiety. But what can we do to prevent the passage of the damage of the faulty gene, if you wish, to the offspring? In this case, the preconception genetic screening will lead to the pre-implantation genetic testing. So up to this point, we were testing the couple. But at this point, we will test the embryo. So we will know more about the embryo before the embryo establishes a pregnancy. And as I said, we have a webinar planned, I believe it's next week, that will discuss with you the details of the pre-implantation genetic testing. But briefly, as I said, we're going to create embryos via in vitro fertilization. We will test the embryos for the disease under consideration, and we will select for transfer unaffected embryos only. So what we utilize to establish an embryo is an embryo that has been tested and screened negative for the disease under consideration. That will substantially increase the chances that you will be delivered of an unaffected child. In conclusion, mutations among asymptomatic people with negative family history are not uncommon. They're a lot more common than you actually think. The goal of the carrier genetic screening is to identify these asymptomatic carriers prior to conception, in the preconception period, not in the perinatal. Carrier genetic screening evolved over the years, and most available panels can test for many commonly seen disorders for a fairly low price, but it doesn't check for everything. Most insurance carriers will cover a portion of the testing for preconception purposes. We will work with you. We will work with your insurance to see whether your insurance will cover the entire testing or a portion of the testing. Knowledge is power. You want to know. And timing is critical. You want to know as early as you can. Knowing will not determine what you do, but it will provide you more options. Available technology can prevent the passage of the affected gene to the offspring prior to the establishment of the pregnancy if the couple decides to utilize this approach. At this point, I would like to thank you for taking the time to be with us tonight, and I would like to take your questions. I see that there are some questions. There is one question that is addressed to all panelists, but for some reason, I cannot read it. So any other questions you might have in the meantime? I can see. There is one that says, my husband and I did pre-implantation genetic screening. And while we appreciate the amount of time saved by knowing how many embryos were euploid, by euploid means embryos that had the correct amount of chromosomes, we still don't know if tests for anything else, if it did test for anything else. Does it test for anything else like how CBS or amniocentesis does? So to answer your question, there are two different types of pre-implantation genetic testing. One is testing for mutations. The other one tests for what you already tested, you and your husband. You did test for aneuploidy. Aneuploidy means that you tested for number of chromosomes. You tested for missing and extra chromosomes. Extra chromosomes can cause conditions like Down syndrome. So when you tested for aneuploidy, you only tested for that number of chromosomes, structure of chromosomes. You didn't really test for mutations. We don't randomly test for mutations. We have to know what mutation we're looking for. As you understand, we humans have millions of genes, so we need to know what mutation we're looking for. Earlier, I used the term spelling error. So think of it this way. If there is a spelling error in one of those volumes of the encyclopedia, there are 46 of them, and each one of them has thousands of pages, unless we know what volume we should be going to, what chapter we should be looking at, and what page is where the spelling error is, we cannot test for all mutations. So when you do PGTA, testing for aneuploidy, you're only testing for aneuploidy. The next question is, I'm older, and I'm wondering, what is the average number of euploid embryos for a woman my age? What is the rate of an implanted euploid embryo of a woman my age compared to an implanted embryo of a woman in her early 30s being carried to a full-term birth? This is also an excellent question. So what we know is that both men and women contribute to aneuploidy. So men and women contribute to this condition of extra and missing chromosomes. However, women contribute the larger percentage. We estimate that women contribute 90% of the aneuploidy. And unfortunately for women, this starts going up high at age 35 and moving onwards. Everybody makes aneuploid embryos. Even 25-year-olds make aneuploid embryos. By 25-year-olds will mostly make euploid embryos. 3/4 of their embryos will be euploid and 25% will be aneuploid. So despite the fact we at a younger age made a large percentage of euploid embryos, we also made a large percentage of aneuploid embryos. unfortunately, as we get older in our 40s, this reverses itself. So we make a lot more aneuploid embryos than we make euploid. So we have a lot of defective embryos, and that on occasion can be 80%, 90%. And when we get at the extremes of reproductive age, it can be 100%. So despite the fact we ovulate, despite the fact we make eggs, they get fertilized, we can make 100% abnormal embryos. Once we are in the lucky situation where we have a euploid embryo, then we have a very good chance that this euploid embryo will lead to a live birth. What is that chance? That chance is around 2/3. 2/3 of patients that get the transfer of a euploid embryo will have a live birth. And that doesn't matter. It's not connected to people's age. Like you can be a 30-year-old getting the transfer of a euploid embryo or a 40-year-old getting the transfer of a euploid embryo. The chances will be the same. There will be 2 out of 3 that if the embryo is euploid, you will have a live birth. The problem is, the challenge is getting to the euploid embryo, getting to the normal embryo. There is another question here that says, I know that gender selection is not allowed, but if there is an X-linked mutation that will certainly be transferred to the boy, are we allowed to select the female gender? That's also an excellent question. And I would say that gender selection is not forbidden. Gender selection is discouraged, because our goal here is to help you utilize the embryo that will increase your chances of getting pregnant and delivering a healthy child. That's our priority. When there is an X-linked mutation, genetic testing has evolved substantially, and we can actually distinguish between the boy that is affected and the boy that is unaffected. So fortunately, you're not forced to make a decision of having only female children. You can have female children that are unaffected and male children that are unaffected. And this will allow you to use 75% of your embryos, while what you were suggesting will only allow you to use 50% of your embryos. So in the very early years, when technology wasn't as good, we were forced to select for sex. But fortunately now, we can utilize all your healthy embryos irrespective of their sex. Another patient is saying here, because of COVID-19, I was offered at-home testing. What kind of a panel is that? So the panel is the same. It will test for the same thing. Instead of testing blood, it will test saliva. So the only problem with that is that a higher percentage of it can miss some information. Not that it doesn't test the same, variety of disorders. It will test for the same variety. Is selection of female gender allowed if an X-linked mutation is certainly going to be passed on to a male offspring? And that's the same question I just answered. Hi, Dr. Souter. I wonder if drawing blood is the only option to get genetic information from the patient. What about saliva? We can use saliva. Just like I said, the only issue with saliva is that we might have a higher rate of false negative. So we might miss, a higher percentage of patients. I believe, though, it is below 6%, depending on the test. Would you recommend a woman to wait to get pregnant during this pandemic? That's another great question. I would say that's the million-dollar question. So as you know very well, we're learning along with everybody else in this pandemic. So far, we utilize information that has been passed on to us from the experience in China and from our brief experience in the United States. And our brief experience in the United States is mostly looking at people that are in the 3rd trimester We're beginning to get some reports about second trimester as well. We certainly have had situations where people that were COVID positive and delivering became extremely sick, required intubation and mechanical ventilation. We don't necessarily know that these people would have had the same course of the disease if they were not pregnant and delivering. What challenges things even more is that we don't know a lot about what the virus does in the early first trimester, but hopefully within the next few months we will. At least women that were in the first trimester in December and January in China are probably going through prenatal testing as we speak, are in their second trimester of pregnancy. So I would hope that we would get more information out of it. Another challenge I bring up to my patients is the fact that, you know, if you need medications to be treated yourselves, you will also be concerned as to what the medication does to your unborn baby. So we certainly do not discourage, openly discourage people from getting pregnant. It's a personal choice, but at the same time, we want them to evaluate the situation, the personal situation, and get pregnant the safest way possible at the time that is the safest. So our governing organs are updating us, the American College of Obstetrics and Gynecology, the American Society for Reproductive Medicine, the European Society for Human Reproduction. All these organizations work very closely and feverishly to be able to answer these questions for us, and we do try our best to update you. Another question says, if my sister has had testing for IVF and she knows she had the gene for a specific disorder, will I carry the same? I would say you have a 50% chance of carrying the same gene. So it does make sense for you to be tested for that particular gene if the gene is not part of the panel. How long do the results take if it is a blood test? That's also a very good question, because we do understand that you are in a hurry, you're eager to get pregnant, and we want you to get pregnant as soon as possible. And we don't want you to feel frustrated that we're delaying your treatments, doing more and more testing. We are on the same page with you. We want you to get pregnant as soon as it is safe, and we will advocate for you. But we as soon as we have all the information we need for your family. So results usually take 2 to 3 weeks maximum. So if you test positive for something and your partner was not tested positive, was not tested at all at the same time, that means now your partner needs to come in and be tested, and we might have to wait another 2 to 3 weeks. I think where it gets really tricky is when you both test positive for something, but it's not clear cut. And believe me, this happens more often than you think. Genetics is not simple. It's not black or white. It can be gray. And when it gets really gray, then I will try to utilize the expertise of one of my colleagues in genetics. So I will try to have you benefit from a consultation with an expert, because although I might know quite a bit about it, it is not my area of expertise. And I want you to make your decisions based on the best knowledge we can get you. So please bear with us when that happens. And remember that it's just like preparing for a war, preparing for a battle. You want to walk into a battle when you're 100% prepared, not semi-prepared. And we will work with you to make sure we get all the information that is pertinent for you to design the right treatment approach. Let me see if there is another question here. Would you recommend getting the vaccine against COVID-19 before getting pregnant or after? Well, I will tell you, I will get the vaccine myself as soon as it comes out. The big question is, when is that vaccine going to come out? How long is it going to take before that happens? And if somebody tells you in 2 months from now, we might have a vaccine and it's safe and get pregnant, that would be great, but we don't know that. So unfortunately, unless we come up with a vaccine really soon, you might have to weigh everything in your family history and discuss the situation with your doctor and kind of make a joint decision of when is the right time for you to get pregnant. And another patient is asking me, when is PGSB recommended? Okay, that's a good question. I guess you're asking me utilizing the term B because we use the term PGTA. So it's not PGTA for alpha, it is PGTA for aneuploidy. So we have 3 types: PGTA for aneuploidy, which will test for extra and missing chromosomes. We have PGTM, as in Mike, that will check for mutations, genetic disorders that are due to spelling errors. And we have PGT for structural rearrangements. Those are the so-called translocations. Those are chromosomes that have broken pieces. And we will talk a little more about it next week when we have the webinar for PGT. But these are the types of PGT that are recommended. So an easy way to remember it is, unless you have a specific genetic mutation in your family that we know of, the only PGT you want to do is PGTA for aneuploidy, because all of us are at risk of having a baby that has Down syndrome or something similar to Down's. All of us are prone to aneuploidy, to extra and missing chromosomes. Another partner is asking me, if my partner has had 5 other children without any diseases, does this factor into whether I need to do the test? Or does that not matter because I'm a different partner for him? I think you've already answered your question, which means I must have done a reasonably good job with the webinar. I agree with you that your partner can still be an asymptomatic carrier, but if he was paired up with a person that did not carry a faulty copy of that same gene, he would only have children that are asymptomatic carriers. If you, on the other hand, happen to be carrying a faulty copy of the same gene, then you will be at risk of having a baby that has this disorder, despite the fact he had 5 other children that were unaffected. So it does make sense for you to undergo the screening test. So let me see. Oh, another lovely patient of ours says, I have gone through several IVF rounds at MGH, and all have resulted in a miscarriage. I have been told that there was probably a genetic problem with the embryo. Does that mean that there was no genetic testing on the embryo before implantation? So first of all, I'm sorry to hear that you already underwent IVF and unfortunately your pregnancies resulted in a miscarriage. There are things we can do to test the embryo for aneuploidy, and aneuploidy is causing 70% of miscarriages. So if your miscarriage was due to aneuploidy, PGTA will reduce your risk of having another miscarriage. It will reduce it. It will not make it go down to 0. It will probably make it go down to 5 to 7%, because there are things that still might not be picked up by the testing. And although we like to think that the testing does not affect our embryos, there is always a small possibility that the embryo might still be affected by something we were not able to pick up. So something to talk about with your doctor. I don't want to say that testing was not done because I don't necessarily know what happened. But that's definitely something to ask your physician and discuss with your physician. So seems like at this point, I have answered all the questions. I am very happy I had this opportunity to chat with you tonight. I am looking forward to our future webinar next week related to PGTA. And I'm looking forward to many more ways to interact with you outside of the office and, you know, educate you as much as I can and as much as my colleagues can on all kinds of interesting topics, because I believe that knowledge is power. So the more you know, the better and the more informed way you can, you know, make decisions about your treatments, and also you will understand a lot better why your testing is recommended. So rather than feeling frustrated about delays, you will know that this is all done in order to help you increase your chances of having a healthy offspring. So at this point, we will conclude the webinar, and I am looking forward to seeing you next week and answer more of your questions. You have a wonderful night and stay safe.